So good morning. I'm Rachel Casey. I am an OBGYN. I've been in DC for a long time. I did my undergrad, my medical school, and my OBGYN residency at GW. And now I'm doing fellowships here at Children's and at Washington Hospital Center in Pediatric Adolescent Gynecology. So, I'm just going to be talking a little bit about OCPs, patch, and the ring. I know many of you in here have probably had, or have definitely had, many more years of experience than I have. So if you have any questions or anything to add, this is not meant to be super formal. This can be interactive. If anyone has questions or comments, just feel free to raise your hand. So some of my first slides are going to overlap a little bit with the talk you just had, but these are the learning objectives for this portion. So we're going to talk about counseling, addressing the advantages and disadvantages of these different methods, talk about the basic mechanism of actions, understand contraindications, and then talk about initiating the method and also about when to use backup methods. I don't think this slide was up earlier, but as you can see, as teens get older, they are becoming more and more sexually active. So the less than 2% of adolescents have had sex by the time they've reached 12 years of age, but 71% by the time they're 19. So it's pretty high, and so this is obviously contraception is a timely topic. And these first few slides are all from the Guttmacher Institute, which is a really great resource. I put this slide up there because it's talking about teen pregnancy rates, and although they are very high in the South, you can see this tiny little dot up here representing DC, which is also one of the highest sites of teen pregnancy rate in the nation. So this is, again, very pertinent day today, I think. Thankfully, it does look as though teens are starting to use more contraception at the time of first intercourse. This doesn't specify the type, but just to say that it looks like this is increasing, which leads us to this wonderful news that there has been a big decline in teen pregnancy. There's been a 51% decline from a peak in 1990, and 15% decline in just 2 years from 2008. So the evidence is mixed about why this is happening. Obviously, there's some political things about, abstinence versus contraceptive sex education, and I don't know that there's any good evidence to say what's the cause, but I'll say, I think that, contraception counseling is obviously quite important. So we're going to move forward talking a little bit more about Miss Angela from this morning. And kind of go through a case, which is just her talking about all the different options, and talk about them a little bit more in depth. So she's 16, she's here, she says she's interested in birth control, and she uses condoms most of the time, but not all the time. So she's coming to your office, and clearly she's asking for contraception, and we know the condoms are not the most effective form of contraception, so the question is, what kind of history do you want to get? And I know that the talk before touched on a lot of these issues. So one thing that we do a lot in gynecology is have a pretty detailed menstrual history, talking specifically about how often they're getting their periods, how long they're lasting, if they have dysmenorrhea symptoms, and is it hot? Is everyone hot? It's a little warm? I don't know. And obviously their last menstrual period, because you want to know if you're going to initiate contraception, you want to know if they could be pregnant. So all these things are really helpful when you're determining what method, mostly because if they have really bad dysmenorrhea symptoms, then you might be more likely to use certain methods than others. Obviously, you want to take a good medical history because there are contraindications to hormonal contraception that are strong contraindications that we don't want to use, specifically migraines with aura, which we'll talk about a little more later, DVTs, PEs, and also family history of blood clots, specifically in first-degree relatives. And then I think the previous speaker talked a little bit about social and sexual history. So you obviously want to find out about what contraception they've used before. If they stopped it, why did they stop it? And what is their lifestyle like, and what's going to work best for them when choosing a contraceptive method. So specifically in adolescents, these are the kind of things that are going to really play in. There's a lot of misconceptions. I've heard things from like, the IUD makes your hair fall out, to very strange things. I'm sure you all have heard a lot of, if anyone has any more strange side effects you've heard of, feel free to share them with the group. Anything weird? I'm sure people have heard weird stuff. A big thing is going to be confidentiality. You know, I don't want people at school to know. I don't want my parents to know. And how do you handle that situation? And then peers. So what are their friends doing, and what are their friends doing at school, and what are they telling them? The cost is a factor, especially if they don't want their parents to know. It will show up on their insurance. So going to a Title X clinic would be an alternative option to get birth control that's not reflected in their insurance bills. So Angela, she's like, okay, well, I had unprotected sex 2 weeks ago, and these are like the first thing that she's probably thinking when she comes into your office is, am I pregnant, and do I have to have a pelvic exam? Because that's what everybody's always freaking out about. And what do you think the answers are? Well, the first one is, I don't know, right? And do I need a pelvic exam? I think was maybe addressed at the last talk, and the answer is, no, you don't need a pelvic exam to initiate contraception, unless they're having symptoms of sexually transmitted infection or something else, some other symptoms are going on down there that you need to evaluate further. So this is from the U.S. Selected Practice Recommendations for Contraceptive Use, and I love the title because it's how to be reasonably certain that a woman is not pregnant. And so these are some really basic criteria that you can use to feel pretty sure about starting your contraception the day that they're in your office. So if she has no signs or symptoms of pregnancy and meets any one of the following. So it's less than 7 days since the start of normal menses, has not had sex since the start of last normal menses, has been correctly and consistently using a reliable method of contraception, which is a big issue in adolescents, is less than 7 days from either a spontaneous or induced abortion, is within 4 weeks postpartum, or is fully or nearly breastfeeding, which we don't see as often in adolescents, but we can see. So just to address the pelvic exams, the recommendations now, which are supported by the United States Preventive Services Task Force and American Cancer Society and American Congress of Obstetricians and Gynecologists, is no Pap tests are necessary until the age of 21. We just had some new guidelines come out just in 2012, and the screening interval for women under 30 is every 3 years. So it's kind of spacing out more and more. So, of course, she says, my best friend has got a prescription for contraception, for birth control. Tell me more. So I think one of the big messages is that OCPs are safe. There's a lot of scary talk about OCPs, but they can be used very safely in adolescents specifically, and have a lot of added benefits if they're used correctly in the way that the patient might need it. So I'm going to touch briefly on progesterone-only pills, and then talk more about combination OCPs. So the reason that we don't talk as much about progesterone-only contraception in adolescents and sometimes in adults is because it's not nearly as effective as combined oral contraceptives. The inhibition of ovulation is variable, and if the pill is not taken every day at the same time, if it's missed by even 2 to 3 hours, it could be ineffective and could result in pregnancy. This particular pill also alters the endometrium. There's a reduced ciliary activity in the fallopian tube and thickens cervical mucus, which is one of the primary ways that it works. The advantages are it's a very, very safe. Progesterone is a very, very safe medication. There are very few contraindications to it. It can improve menstrual symptoms. So the way that the progesterone-only pill is taken is it's an active pill every single day for all of time, for as long as they're on it. So they don't have any periods, any bleeding whatsoever. So it's a very simple, fixed daily regimen, hard to mess up unless you forget it. It can result in breakthrough bleeding, which can become annoying and frustrating in some patients long term. As I mentioned, the efficacy is vulnerable, and I think this is something that should really be used cautiously in teenagers, just because it's not quite as effective. There's also a possible increase in functional cysts because it does not always suppress ovulation, but functional ovarian cysts are something that come every cycle and resolve. So these should all resolve and go away on their own. So for combination oral contraceptive pills, there's a lot of good data about how these work. It does thicken cervical mucus, and the bulk of the data is about how it suppresses ovulation, which is done via negative feedback. So it decreases the GnRH pulsatility, decreases pituitary responsiveness, and suppresses LH and FSH, and most importantly leads to inhibition of the mid-cycle LH surge, which is what leads to ovulation. The other two mechanisms of actions are not as strongly supported in the data, but presumed to also be mechanisms of action because of the progesterone, and those are decreased tubal motility and endometrial atrophy and localized edema. So what are the advantages of combination OCPs? So there's a lot of them. The first one is that it can be very, very effective. When taken correctly, the failure rate is 0.3%. However, in the real world, the efficacy is 8%. So there's a lot of people that don't take it correctly. I mean, it's a pill. You have to remember to take it every day. And one of the statistics that I found from Guttmacher was that about 33% of adolescents are adherent after 1 year of use. So it's not something that, as if you attend the LARC talk, this may not be the best method for everybody, but it's something to definitely consider. It's very safe, as I talked about. It's reversible. So after just 2 weeks of being off of it, ovulation should resume normally, and they can attempt pregnancy if they desire. The side effects are minimal and usually will resolve if they continue on the method. So nausea, headache, breast tenderness, and we'll talk about that a little bit more. The menstrual symptoms are what can be a big benefit of OCPs. So if they're having really bad dysmenorrhea, really, really bad cramps, they're staying home from school 1 or 2 days a month, then OCPs are probably going to be a really good option for them. If they have any anemia, we see a lot of girls with heavy menstrual bleeding. It decreases the blood loss and potentially anemia. It would also decrease anovulatory bleeding, so your girls who just recently started their periods and they're having very, very heavy irregular bleeding, which is usually due to anovulation, this can help control that for a period of time just to get them over that first period of menarchal and ovulatory bleeding. And also would, like I said, decrease ovarian cysts because we're preventing ovulation. So every month women have a functional cyst that contains the egg, and most of the time it just goes away, but sometimes it can turn into a cyst. So if you have somebody who's having recurrent ovarian cysts, then this is a potential option for suppressing the formation of those cysts for a time period. Also important are health advantages, decrease in ovarian cancer, endometrial cancer, depending on the pill, decreased acne and hirsutism. Also, we use oral contraceptives a lot to treat endometriosis pain, and can also help decrease benign breast disease. Any questions, comments? No. I know this is really dense information, yes.
Are there certain ones that are better for this scenario if the girl is continuing to have pain on OCPs? Can you change them?
Right.
Logic to how you change them?
To be perfectly honest, I just feel like there's so many different kinds of pills, and most of the time we're using like the same few. Me personally, I mean. I don't know that changing, I think it's worth trying to change the pill. I guess you could try to go up on the estrogen dose, but also with increasing the estrogen dose would increase side effects. The other thing we do a lot with people with really, really bad pain is just suppress their periods completely, which is usually what we end up doing.
Is that more of a sign that it could be endometriosis?
Yeah, definitely. That there could be something else going on. So it could be endometriosis, it could be something else called adenomyosis, it could be that they have some type of uterine anomaly. So usually when we see girls that come in and they're having really, really painful periods, they've been on continuous oral contraceptives, they're not getting better, then we move to do imaging, make sure that there's nothing abnormal, and then ultimately down the line they end up with a diagnostic laparoscopy just to see if there's endometriosis inside, after which sometimes we'll use other things like Lupron and stuff to suppress the pain depending on how bad it is. So, as I'm reading my notes, The estrogen causes hypertrophy of adipose tissue. That's the first part, which will lead to the nostalgia. The benign breast disease, specifically fibrocystic breast change, cyst and fibroadenomas, I don't know quite exactly what the mechanism of action would be, which is kind of interesting because they're saying that there's like hypertrophy, but I would imagine that in some way you're kind of stabilizing the hormones and when you're kind of leveling things out. So that's my reasoning, but yeah. Any other comments or questions? So some of the disadvantages we talked about are daily administration, which can be very hard for some teenagers. The expense, if they don't want to have it covered by their parents' insurance. There are now, I think there are like $4 ones available at where, Walmart, Target, yeah. So that's a huge thing to remember. Access can be an issue, like if they're 15 and they have to go to the pharmacy, or if they're younger than 15 and they're trying to get to the pharmacy, is that something that's feasible for them or not with school and their parents and stuff like that. And storage and ready access. So you've got a teenager who needs to carry around these pills and they're trying to hide them from, I don't know, their parents or other kids at school. Where are they going to keep it, and so that they have it when they need to take it? Yeah. No.
Can you comment, or do you know anything about majority, 75% of the girls I have on OCPs see nothing because I guess it's Affordable Care Act. And then there's a few who are telling me $5, $10. Do you know how that works?
I don't. I think, but you're right with Affordable Care Act. I can tell you with my own insurance, like it's pretty unbelievable the changes that have happened. But I'm not sure.
Yeah, I just wonder why I'm having some people tell me they're paying. Some pay a fee,
but it might, do you know the answer?
These are all private insurance.
Huh.
Private insurance, you have to pay like $5,000. So majority, at least 70% of my private are not paying. So I don't know. It makes me feel
I think it's probably can.
So if it's free under the Affordable Care Act, does it still show up in parents' insurance?
I don't know that it's necessarily always free under the Affordable Care Act. Yeah, but yeah, that it's covered, but maybe different insurances. It's supposed to be, but I can tell you even from that's not always the case, and I don't know why. Especially in different states, they may not be participating in the same way. I don't know the answer.
Is it government insurance versus non-government?
That's what it is.
No, it's supposed to be.
It is supposed to be everything.
It does maybe depend on the brand. Maybe you guys comment on the there's just a few that you recognize.
That's definitely true. The generic brands are probably what.
Can you give us some specific names in what to use and what to and how you approach it? Because we're out here,
Yeah. Okay, so side effects probably most of you are familiar with. Nausea, headaches, sore breasts come from the estrogen effect, and the progesterone is edema, abdominal bloating, and the menstrual irregularities, or the breakthrough bleeding, which people complain of. So all birth control, even when it contains estrogen, is still a progesterone dominant, is how we kind of talk about them. So one thing that we see a lot is if girls have been on pills for a very long time, they'll have that breakthrough bleeding, that spotting, or if they're taking it continuously and they're having irregular spotting, a lot of times what we'll do is have them stop the pill for 4 days, have a bleed, and restart them. So the risks associated with it, probably most of you are pretty familiar with. One of them is hypertension. It can only be 3 to 5 increase, but so if it increases dramatically, immediately, then you should stop them. And once you stop them, it typically will go back to normal. So the next risk is cholestatic jaundice. So there is some impairment of active transport of bile with cholestatic jaundice. And this is rare, but it's just something that I think is kind of interesting and good to know about, which is pertinent to me because if you have a patient who in pregnancy had cholestatic jaundice, that's something to kind of be aware of and wary that maybe you shouldn't put them on OCPs. Also, there can be a risk of hyperkalemia, so the drospirenone-containing OCPs, which is a fourth-generation progestin, which we'll talk about in a little bit. Those patients, if you're started on those, they should be monitored for hyperkalemia. Hepatic neoplasms, hepatic adenomas are associated with OCP use. Again, they're rare, and there's no increased risk of cancer whatsoever, but it's something to be aware of. And finally, the one that we talk about the most, which is the venous thromboembolism. So there is an increased risk, but the absolute risk is still very, very low. And this is specific for adolescents. So a lot of things change with combination OCPs when women get older, when they're above 35, if they have other health risks, if they're smokers, obesity. But in teenagers specifically, it's still a very, very low risk. And the risk is about 0.5 in 10,000 for women under 20 years old. So just to put things into perspective, comparing what the risk specifically of pregnancy, which is really important to remember, is that young women, the incidence in the general population without OCPs is 4 to 5. Pregnant women is significantly, significantly higher. And there was a higher incidence when we were using contraception with 50 microgram pills, 50 micrograms of estrogen, which we rarely use these days. Almost every pill that is being used is low dose. So the incidence is much lower. But again, when you look at the relative risk, it's higher but not alarming. So then there's some other risks that I would mention. I don't know if anyone has any thoughts about these ones. Yes, no, probably not. So these are not typically very risky for adolescents. So pregnancy, if somebody does get pregnant on pills, there's no increased risk of birth defects. There's no additional prenatal testing that needs to be done from the exposure. For myocardial infarction, again, in young, healthy non-smokers, there's no increased risk. And the same for the stroke, there's no increased risk. And these are all for low-dose pills. So as I said, we don't really use high-dose pills anymore. Not never, but most of the time we don't. I just thought I would mention medication interactions because I think that's probably something that everybody encounters at some point. So OCPs are metabolized by the liver, and there are certain medications that will either increase or decrease the amount of circulating hormones, which are listed. I don't know if you can read them pretty well right here. And then these ones on the right, which I think are really, really important to know, they may increase the amount of medication in the body while they're on OCP, so they can still safely take it, but their level of lithium or diazepam will need to be lowered while they're taking them. But again, if they're on this long term, then it's probably something you should be considering a different form. So I know somebody earlier mentioned the U.S. medical eligibility criteria for contraceptive use. This is a really, 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 really great resource, and it's online. It's easily accessible. Yes, it's in your folder. It's amazing. It's a 2-page thing. You can just hang it up on the wall and refer to it all the time. They even make these little wheels. I have one, but I'm not willing to part with it, where you can just kind of spin around and see where you are in the grade scale. So 1 is basically very safe, no restrictions, and 4 is that it's unacceptable due to health risks. So this is what it looks like. It should be in your folder. Again, if you lose it, it's really, really easy to find. I'm going to give you a little bit of a close-up of what it looks like. So this is specific to headaches. So you can see they categorize the headache, right? And then they have sub-conditions, so non-migrainous and migraines, and then they have without aura, with aura, and then they specify based on age group. So you can see here the way that they group it. I don't know if anybody's familiar with this yet, but everything I'm talking about today is all in one group, besides the progestin-only pills. But the medications and combination pills, patch and ring, are essentially in the same group. So for non-migraine, so like cluster headaches, tension headaches, they are pretty safe, grade 1 or 2. And then obviously with an aura at any age is an absolute contraindication. And then there's the injection, implant, the Mirena IUD and the copper IUD. So this is something that I reference all the time. It is extremely expensive, so even sometimes if you have some weird condition that you're just not sure of, is there going to be an interaction, even if you're not prescribing the pill, but you're just taking care of them inpatient or something and you want to know, this is a really, really, really great resource. So, Angela's exhausted. That was a lot of information, and now she just wants to know, how am I going to take the pill? But interestingly, there was something on NPR this week. There was an article about what women want to know about their contraception, and that as providers, we tend to spend a lot of time telling them how to take it, but that most women actually want to know, is it safe and effective? So I just thought that was interesting, because I know with teenagers, we spend a lot of time saying, okay, make sure you take it the right way and all this stuff. So when do you start it? So there's different ways to start it, but the truth of the matter is you can start it any time. So for combination OCPs, they kind of term the quick start, first start, or Sunday start. And I think that the best start for the patient is going to be whatever is going to have them actually take the pill. So if remembering to take it on a Sunday is going to be a good idea for them, then maybe that's a good idea. However, it's important to remember that pharmacies are usually closed on Sunday. So Sunday start is probably not a great idea because they most likely are waiting till the, well, not most likely, but may be waiting till the last minute to get the pills. And then the first start, if you feel reasonably certain that they're not pregnant, they can start it the day that they come in. Once they start it, they need to use the backup method for 7 days. And the one thing that you should be checking is their blood pressure to make sure it's not elevated before you start it, and then having them follow up to make sure it's not elevated, usually about 3 months after. For progestin-only pills, again, you can start at any time, and you actually only need a backup method for 2 days, which I think is really interesting. But it's because it's not suppressing ovulation. But again, as I mentioned, this is not an extremely effective form. So how can you take them? So there's monthly cycling, which is the one at the top right. So you have 3 weeks of active pills and then 7 days of placebo pills. And then there's the shortened pill-free interval, which is what this low estrogen iron is at the bottom. So that's basically that there's 4 days of placebo pills, which, you know, interestingly in some of the reading I was doing for this talk, that's kind of, I think the movement is gonna be towards a shortened pill-free interval. There's some data about that, I think it was about 10% of women by the 7th day of placebo will have a follicle in their ovary. But very, very few of those follicles will actually result in pregnancy if they start their pill right away. But that's one reason to do a shortened interval, and another one being decreasing bleeding, and I guess in some ways preserving iron stores. And then there's the extended cycle use, which we mentioned a little bit, can be really good for patients with pelvic pain and dysmenorrhea. So the Seasonique, Seasonal, that's the one that a lot of people use, and I think there's a generic one now. So that, you know, we a lot of times will prescribe a generic non-Seasonal or Seasonique and tell them how to take it, but I kind of think for teenagers it's super easy to have this big pack and they just know, okay, open the pill and just start taking it and just keep taking it until it's over and then start the next pack. So there are ways to manipulate the other ones, but I think that for this age group that might be very helpful. So what am I taking? So most of the pills contain the ethinyl estradiol, and there's really not a big difference in the estrogen in most of these pills, but the big thing is the difference in the progesterones. So the first generation is the norethindrone, which is tolerated very low. This is ones that were used a while ago and aren't used as much now. It's a very, very low dose, and women tend to have a lot more spotting associated with it. The second generation, these are much more potent and long-acting. So an example would be levonorgestrel, which is what's in the Mirena IUD. So that makes sense that this is the one that's used in the Mirena IUD and the implant, a second generation, the implant, because it's long-acting. The third generations are the ones that are used the most commonly, and they have the least androgenic effects, so it's good for people with acne. And then the fourth generation, which is like the Yaz, which is derived from spironolactone, has anti-androgenic properties as well. And as I'm sure all of you have heard and know that there's a slightly increased clot risk. Again, I would say that the absolute risk is still pretty low, so you just have to kind of gauge if this is something that this patient really would benefit from. Yeah. Yeah.
Give an example of like the common one.
Yeah. So, I mean, most of the pills that we use are third generation. So the loestrins and, I don't want to misquote, let's see. The example. I don't have a good list. I don't want to tell you wrong, but many of the pills are third generation. I do have a list in my office, but I can't tell you off the top of my head.
Is there a list on how to reference easily that puts them in?
Yeah, there's actually a really, really great table that somebody created that goes down the line of like side effects or, you know, if there are mood changes or, you know, acne and different things like that and what progestin is going to be best suited for them. If I can get it and get it in, I can scan it in and see if I can send it out. I'd be happy to do that. It's really, really helpful. Yeah.
Do you happen to know where the cycles fall in?
I mean, I can look it up right here. Okay. The phasics also, so these are ones that change the dosing as you go along. These are a little, I don't know, in my mind, I think a little bit old school. We personally don't use them very often. This is kind of how the pills first started, was to kind of like mimic the menstrual cycle. So I think one of the benefits is that they may have less breakthrough bleeding, but truthfully, we don't use phasics a lot. Again, I know that most of you are already very familiar with the importance of counseling them to talk about what is their adherence going to be to the method that you're choosing. We have a lot of girls that use their phones for various things associated with their period and contraception, and find that a phone alarm reminder is really helpful. To, tell them that the side effects are usually transient, and as I said, I'll set out that table that there's a lot of different pills, so if somebody's not happy on one, there's like 75 different types of pills. There's going to be something else that they can try. And just as a reminder, if they miss one pill, it's okay to take it when you remember, and you don't need a backup method. If they miss 2 pills, then they need a backup method for 7 days. If they miss 3 pills, then they need to start over, basically. Yeah.
And missing is within that 3-hour gap. Is that what I'm hearing? So, like, if the kid is taking the next day, 3 hours after, like, oh, I took it, does that count as taking it a second day? Or we're talking about not taking it at all?
Not taking it at all. So for the progesterone only, they need to take it within 2 to 3 hours, but for the combination OCPs, they have a little bit more leeway. So there's, if they miss it for 24 hours, I guess that's it. So they miss it, yes.
What if they miss it not 2 days in a row, but multiple times within a cycle? At what point does that kind of mess things up? Sometimes
right, they miss one, and then they're like, okay, I don't need the bath. I would tell them they probably need a different method. And that, honestly, that's what I would say, because how are you going to know?
If they've missed it more than
if they've missed like one pill, and then they took it, and then they took it regularly for 3 days, and they missed another pill, it's probably still effective, but I don't know that there's a lot of good data about what happens when they miss this many and that many. And they'll get frustrated with it too, because they'll start having bleeding and all when they stop it.
Do you have a good handout that goes through all this for the kids that you use?
There is a really good website, so we use, and I have it at the end, but there's a couple really good websites that we give to all the girls. One is youngwomenshealth.org, and that is one that we use for a lot of our peds GYN stuff, but it has a lot of good information about contraception. It's accurate. It's put on by Harvard. And then there's another fun site called the Bedsider, which probably maybe many of you have heard about. And that's kind of like a fun interactive site that has a lot of accurate information. But we usually print out the information from Young Women's Health. That's our kind of go-to. But they also have things for an ACOG that has good information, but the Young Women's Health is kind of geared more towards adolescents, so I find that one to be helpful. They have PDFs and everything. So I'm going to talk just briefly, we have about 10 minutes, about the patch and the ring. So I honestly can't remember the last time I prescribed the patch. I don't know, does anybody use the patch? Sometimes, yeah. It might be a good thing for somebody. So this is literally what it looks like. It can go anywhere on their bottom, on their arm, on their abdomen. It has a 3rd generation progestin in it. You apply it once weekly for 3 weeks and then have a one patch-free week. I believe there is one patch that that's newer that can be used for 3 weeks. The failure rate with typical use, so this is not when they take it, they use it very regularly, is about 9 in 100 per year. And for backup, if they have it on for greater than 9 days, so if they're supposed to change it at 7 but they leave it on for an extra day, it's not a big deal. But if they leave it on for more than 9, then they need to use a backup method. Or if they take it off for more than the 7 days of their patch-free week. Or if they take it off to go to the beach or something for more than 24 hours, and they should also use a backup method. This can be a really good method, which is why I'm assuming some people are using it, because it's a weekly regimen, so it's not a pill every day, so they don't have to remember to take it. It's pretty forgiving with if you forget for 7 days to change it or take it off, you have a good 48 hours. It's rapidly reversible, so 86% of women will ovulate in the first month. It adheres well. It's verifiable, meaning like you know that they're taking it or they know that they're taking it and they're not forgetting. It doesn't interfere with intercourse, so it's not in the vagina like the ring. And it's something that they can hide pretty easily, so it can go under their underwear. They don't need to take it off to go to the beach. They can put it under their bathing suit. And so that's something that's probably appealing to a lot of adolescents. Some of the disadvantages are the same as with the pill, so there could be an expense and access issues. There are risks of estrogen effects, which are slightly higher in the patch. The patch may be detached, however, it's pretty low, so about 2%. Some girls get really turned off by the sticky skin irritation, and they just think it's gross and don't want to use it anymore. It needs to be stored at room temperature, so they can't forget and leave it in the car for 5 days. And one of the big things is that the effectiveness is reduced by a high BMI. So there has been shown that greater than 90 kilograms, there's a lower serum circulating estrogen levels at higher BMIs. So that's one of the, yeah.
But it has only a 9 in 100 effectiveness?
For typical use.
I mean,
yeah.
Typical use.
Meaning so they call it perfect use. If someone's using it perfectly, then it's lower. But for how people usually take it, yeah, that's kind of the terminology that they're using. I just put in a little bit of information about the clot risk with patch because it is slightly higher. Again, it's slightly higher, but still the absolute risk is low. But it's still something to be aware of, and that's something that we should be counseling our patients about. So there were 2 big studies that were done. The first of which was Sheikh et al., who looked at the VTE risk with patch and compared it to 35 micrograms OCPs, which is a slightly higher dose. You know, we usually have 30 micrograms, and mostly using 20 micrograms, and found that there was there was a 5.3 per 100,000 versus 41.8, so slightly higher, but there was no increased risk of stroke or heart attack. And so Cole et al. Found something slightly higher risk comparing the patch users, stating that it's more than double the risk. So it's just something to be aware of. Again, you're kind of tailor-making what the right contraceptive choice is for with your patient, so it's just something to be aware of. The last thing is the vaginal ring, which I think is a really, really great option, but I don't know how many teenagers of yours are comfortable putting it in or taking it out, and I think that might be one of the issues with it. This is something that can be put in for 3 weeks and then take out for 1 week. Again, the failure rate is about with typical use, so how people usually use it, is about the same as with the patch. If it falls out in the first 2 weeks, it can just be reinserted. But if it comes out during the 3rd week, then either you need to put in a new ring because you're going to keep it in for longer, or just let them have a period and restart it after 7 days, and make sure to use backup for 7 days. So I said this is very effective. It's basically similar to a 20 microgram pill, so our low dose pills. It's private, it's simple, easy to use. To me, I don't know if that's going to be simple and easy to use to all teenagers. It's rapidly reversible. It has all the benefits of combination OCPs, and they can, if they have sex and their partner feels it, you can take it out for up to 3 hours, and then put it back in afterwards. Disadvantages: monthly administration. Again, the estrogen side effects. Some people do feel it during intercourse and don't like it. Some people do complain about vaginal irritation or vaginal pain from it. Not a lot that I've heard of, but it can happen, so don't discount it, and it may not be due to an infection. And the ring expulsion rate is pretty low. So, yeah.
Other than just minor irritation?
You mean the release of estrogen and what it's doing to the tissue?
Yeah.
So the way that it's absorbed in the mucosa, so just like if you were putting something in your kind of like buccal mucosa, and I kind of, I don't know about if there's good data on it, but, a lot of the times any type of any type of birth control can cause vaginal dryness and things like that. So I don't know if there's something that's going on when it's being absorbed locally. Maybe. But I've never heard of it. So then my last piece is, what is the best method? And obviously it's up to her. So I think it's really, as many of you know, it's really about personal circumstance. What's their medical history? What's going to be safe for them? What are they most likely to take regularly? And specifically issues of confidentiality with their peers or with their family and friends. These are the resources that I mentioned. Young Women's Health is something that we use a lot. They have a good contraception section, and they have information about all different kinds of other problems specific to adolescent girls. I would not be an OBGYN if I didn't end by just mentioning that we really feel as a OBGYN community that adolescents and long-acting reversible contraception is something that we should really be considering. They are very, very, very safe. They are very reliable. We know that they are not going to forget to take it, and we're starting to do a lot of them, and I know that they're doing a lot here in the adolescent clinic, as well as are we as OBGYNs and adolescents. So I don't know if any of you are going to the LARC talk, but we're putting IUDs in teenagers. You don't need to have had a baby. You don't need to be low risk for having PID. You can still get an IUD. So this is the little phrase from ACOG that IUDs and implants are the best reversible methods for preventing unintended pregnancy, rapid repeat pregnancy, and abortion in young women. So I have to say that because that's what we do.
What are the positives to what we talked about today as opposed to the long-acting?
What are the positives?
Like why would you take this route as opposed to?
I mean, I really think again, it's dependent. Some people are like, I don't want that thing in my arm, or I don't want that thing in my uterus, that's gross. The dysmenorrhea symptoms, so the pain with periods, there is evidence about that IUDs and implants can help with it, but I think that you have a little bit more wiggle room with the pills, especially if you're kind of using the pills as almost as diagnostic to see if you kind of suppress their ovulation and level out their hormones. Are their symptoms going to get better? There are health benefits to the pills, but if specifically for pregnancy and not other things, I think just to at least be considering LARC use, yes.
Can you comment for a second on combined oral contraception for obese patients? So like
Yeah, I don't know that I have a lot of good information to comment on. I had it, but I don't think I included it in here. And I didn't bring my book, but I'm happy to find some information and send it out. There's a really good book. It's called The Essentials of Contraception, and it's the most in-depth, awesome, amazing book about contraception. It's like this thick, but it's little. And it has like everything you ever need to know about contraception in it. And they do have a section on obesity and contraceptive use. But I don't believe that there's a, I don't know the latest literature. I do know that with the patch, obviously, that there's decreased efficacy. But
that's sort of related to this question. I don't know if a girl, I'm thinking more like young adult, comes in and you diagnose it, they come in with a diagnosis of polycystic ovarian syndrome, if it's still in the first. What is gynecologists recommend?
We are doing, we spend a lot of, we give a lot of PCOS patients birth control pills, mostly because a lot of them will either become amenorrheic if they're not getting their periods, or they're not getting them often enough. And obviously, if they're not getting them often enough, they can be at risk for endometrial hyperplasia in the future. We tend to use, our go-to kind of is like Cristel. Cristel, it doesn't, you know, it's a 30 microgram pill, but to be honest, I was just talking with one of the pediatric endocrinologists about this, and what's the difference between a 20 microgram and a 30 microgram? I think sometimes we'll start with a 30 microgram and kind of thinking if they're going to be better anti-androgenic effects, but if they're not tolerating the 30 microgram, then we just go down to the 20, you know. So there was something else I was going to say about the obesity part. Yeah, it's CRYSELLE. And when I send out the information about the different progestins and estrogens, it'll have a lot of like the brand names associated with those different medications. It's a really awesome thing, so I could find it today.
So I know that thinking about adolescents, when you talk about seasonality, and you like to keep with it, but just give us the other information. If you want to use a regular birth control pill, does it matter which one you use if you're going to do it for 3 months? And is 3 months the limit, or are you going longer?
You can go, technically speaking, as long as you want. I mean, there's not really a limit. There's nothing bad about not getting a period, except that eventually they're going to have breakthrough bleeding. And as I mentioned, if you're going to suppress periods for, say, 6 months and they're having breakthrough bleeding, one thing that we tell girls to do is just stop the pill for 4 days, have a period, and then start back up again. So you can really use any pill, and you just write it in a way that they'll give them 3 packs. So that's one of the access issues. So if you're trying to give somebody a pill pack to take continuously, is the pharmacist going to give them a hard time? I haven't had that happen, but we do a lot of continuous without, yeah. But we give a lot of continuous ones without using seasonality.
And over, like if you start them and you say try for 3 months and they break through bleed in the middle, do they stop and resume and try for 3 months again, or?
I guess it depends on why you're suppressing the periods. And how important it is to suppress them. So if they're
severe dysmenorrhea.
Yeah. So probably for that, they can try another 3 months, and then the question becomes like, what's worse, the dysmenorrhea or the breakthrough bleeding? And then at what point, if the dysmenorrhea is so bad, do they need some further evaluation? In which case, we're happy to see them here. But it's just kind of like what's worse in my mind. So if they're like a heavy bleeder and they've been anemic, and now they're, you know, requiring iron supplementation, then yeah, it's probably pretty important that they're suppressed for 6 months. We don't want them to break their spot, but at least they're not having these heavy bleeding. So in that case, I would say absolutely go try for another 3 months.
Does it make any difference if you're trying to use the pills for someone who has some kind of mood disorder, premenstrual syndrome, psychiatric problems with that pill you use?
So there is no good evidence to say whether or not pills help with that. However, I will say, but there is some information about suppressing the periods completely. So we actually have a patient who was having psychotic breaks with her periods for a very long time, and finally suppressed her periods, and she hasn't had another psychotic break. that's not something that's going to be in the literature, but I think kind of suppressing the periods completely, I think that there may be benefit to that, and it's absolutely worth a try. Saying that OCPs are very safe, so if somebody is having really bad, PMS, PMDD, to try suppressing their periods for 3 months and see if they're feeling better.
What I've read is that that you do want to have a period at least 4 times a year to keep your bones. Much about the association with, like, if let's say we're suppressing your periods for a year, are you affecting your both entities?
No, because you're giving them estrogen. So in some cases, we actually use OCPs for estrogen replacement. For people who've had cancer and they're gone into like ovarian insufficiency. So I don't have data. I can't tell you the data on it per se. I'm absolutely sure that there's something in this book that I could look up for you. But no, the bone density, the bone health stuff comes with the depot. Is a big thing that they always talk about. Any other questions? Yeah.
When you can switch from an OC, the oral contraceptive to the depot?
When can you?
Yeah, in what instance, in what circumstance?
Like, why would somebody want an injection?
Yeah, because the depot is a persistent period as well.
Right. Or can cause irregular bleeding and potentially heavy bleeding. So, again, I would really say it's just totally up to the patient. Yeah.
I've noticed a lot of time when the patient, they're flowing for like the first 3 months, like this young lady, she got a step, so she should have got a shot this month, and so she came back to the hospital. I've been bleeding every day. I said, how many pads are you using and stuff like that? So it's like, I'm bleeding too much. I don't want to be on this step and stuff like that.
So what can you do? Depot, again, is like a really safe progestin. You could start them on OCPs on top of it, or you could give them an IUD on top of that. So those would definitely be other options, and let it run out. I will say that, interestingly, because we had a consult and I was reading about this, that we think the progestins are very, very safe, and their clot risk is much, much lower, and the safety profile is much higher, but it's not zero. And I think that there's still a lot that we don't know about the progestins. And specifically, the one that's used in depot is slightly higher than other progestins. It's still not on par with estrogen, but I just think it's something interesting to think about. Like, we have so much data on OCPs. They've been around for 40 years now. But again, now we've got 4 generations of progestins, and there's things that we may not know about them. Yes?
So going back to the start of the pill,
yes.
When
Somebody comes in and
it's in that frame where you can't
test whether they're pregnant or not, when do they start, or you just say start it, and if you don't get a period, then come in and we'll test it?
So if you're not sure if she came in, so right at the time of ovulation, especially, it's usually how it is, right? Then I would just have them start the first day of their period. Yeah. Does that make sense? Yeah.
Quick question. So in the past slide, I saw downstairs actually that if there's a family history of clots, then go ahead and do a basic diagnosis disorder evaluation. What kind of basic labs do you all typically send if you don't do that?
So we don't typically do that. I think the goal is to find out why that person had a clot. And there is actually, in the U.S. medical eligibility criteria, there's a whole section. I almost use that instead of the headache. There's a very specific section about, first degree relative. Why did they have this clot? Was it from surgery and they were immobilized and that's why they had the clot, or is it because of an underlying clotting disorder? And that would kind of guide you whether or not you would give them OCPs. Yeah, but if if it's their relative that had a clot, they probably did have some type of workup, depending on what the circumstance was. So you want to find out what it was, how is it inherited, and could